After learning about the basics of management of diabetic retinopathy, let's now move on to some special situation. And one such situation which everybody faces now and then is cataract. Because cataract is common in diabetic retinopathy, we need to remove it to visualize retina. And many a times you may have to do cataract surgery along with vitrectomy. There are certain important considerations when we are doing cataract surgery in diabetics. The first is a very good preoperative evaluation to look at the grade and the hardness of the cataract so that you can give a realistic goal to the patient. Preoperatively, pupillary dilation is an important, so make sure to assess preoperatively that pupil dilates very well. Many a times, these patients might have trans illumination defects in the iris, which means you can expect more intraoperative iris prolapse and be ready for it. Whenever possible, try to do OCT angio before surgery. If it may show you areas of non-perfusion in the fovea, which will tell you that the vision post-surgery may not be optimal. Many times OCT angio will not be possible, but OCT will be. So it's important to document if the patient has any pre-existing macular edema. Beside that, the preoperative evaluation would include the checking the level of HbA1c, control of blood pressure, and kidneys. When to do surgery, avoid unnecessary delay because that will worsen the fundus view. We have to optimize the glycemic control and renal status, and we prefer early surgery if there is poor visualization of fundus and diabetic retinopathy is progressing. Intraoperatively, patient might have severe comorbidities, so you may prefer to have monitoring under anesthesia wherever possible. Pupillary dilation, you have to be ready with intracameral preservative-free epinephrine. Phaco should be performed with the machines which are powered with modern duty cycle, and techniques like vertical chop may be used because they cause less posterior capsule stress. Minimize surgical time, reduce phaco energy, maintain stable anterior chamber, and as far as possible, prevent posterior capsule rupture, meaning we need a very experienced surgeon for these eyes. Regarding using the IOL, monofocal should be preferred. Don't put multifocal, especially if there is diabetic retinopathy. Hydrophobic acrylic lenses are preferred. One of the major issues with diabetic is that you have done a beautiful surgery, but there is worsening of diabetic retinopathy as well as diabetic macular edema after surgery. Now, this is an example of a patient. You can see this photo is before surgery. After surgery, which is uncomplicated, there is worsening of macular edema. Not only the macular edema, the proliferative and non-proliferative components themselves can also worsen. This photo shows worsening of non-proliferative component of diabetic retinopathy. This one is the patient before cataract surgery, and unfortunately, he had a complicated cataract surgery with posterior capsule rent. And following this, there was development of both macular edema as well as worsening of PDR and vitreous hemorrhage. So, what happens to macular edema? As I mentioned that before cataract surgery, it is important to do OCT to look for macular edema. And if you find a very significant macular edema before surgery, anti-VEGF should be given before you plan surgery so that there is minimal macular edema at the time of surgery. Now, this patient, for example, before cataract surgery had a very minimal thickening which was not involving the center. However, Post surgery, you can see there is worsening, which means that they would need some adjunct for macular edema along with surgery, and you can see the cystoid spaces which have come up. It used to be very common to give intraoperative anti-VEGF injection, and is still very common that you do cataract surgery and you combine it with intravitreal anti-VEGF. This is the patient with preoperative macular edema, and surgery was done with intraoperative anti-VEGF. There are different protocols depending on your comfort level. You can give anti-VEGF few days before cataract surgery or along with the cataract surgery. However, there are situations where anti-VEGF may not work. For example, this is the patient which had complicated cataract surgery, and you can see there was no response to anti-VEGF because these are the eyes where the inflammatory mediators are very high. So they cataract surgery causes inflammation, which causes cystoid macular edema. So giving anti-VEGF may not take care of the inflammatory component. Long time ago, we published the first paper that the treating diabetic macular edema uh, in patients who are undergoing cataract surgery and combining cataract surgery with the DEX implant would take care of diabetic macular edema in the postoperative period. The results were very dramatic with lot of difference between the group that received Osidex compared to those that did not. Now, I will show you an example of this. It's a 60-year type 2 diabetic. She has DME and she has, macular edema, which had responded to triamcinolone in the past, but last injection was given more than 3 months in advance. So she had cataract. So she underwent DEX implant and cataract surgery, and you can see the diabetic macular edema resolve. So there has been a recent article on cataract surgery with or without center involving DME, and the results show that if you do not do any additional therapy during surgery, the patient will demonstrate a significant worsening. And this worsening was evident both in terms of visual acuity as well as the central thickness on OCT, which means whenever you are planning, go you may have to combine it with adjunct therapy, which could be Osidex. I use Dex implant a lot because the main culprit for cystoid macular edema is inflammation. It is not VEGF. But if you are comfortable with anti-VEGF, that too can be tried. Now you have done everything. You just have to remember and probably include it as a part of your consent that there is a risk of postoperative infections and corneal endothelial damage, which is slightly higher in diabetic patients compared to non-diabetics. So this is what our group published about Aspergillus niger endophthalmitis, which was more commonly seen in diabetics. If you're concerned about the endothelium, confocal microscope can be used, but I think more important is protecting the endothelium during surgery by keeping the chamber maintained all the time and using generous viscoelastic to protect the posterior part of the cornea. So the clinical pulse is always evaluate retina before surgery, treat diabetic macular edema wherever possible before cataract surgery. You need a tight glycemic control because that's going to improve the outcome. Intraoperatively, adjunctive treatment with steroids or anti-VEGF, and a close follow-up is essential. Thank you very much once again for your patient hearing.